session, we shall be discussing instrumental or operative vaginal delivery. Instrumental delivery and operative vaginal delivery essentially means the same thing. Both are used simultaneously in the literature. The increasing cesarean section rate globally necessitates the need for us to look for an alternative method of delivery to reduce the increasing cesarean section rate. And therefore, in this lecture, I will expect you to know what constitutes instrumental or operative vaginal delivery. I also expect at the end of this lecture, you know the types of instrumental or operative vaginal delivery. And I expect that you be able to make a list of indications, prerequisites to use, and their complications of these various methods of instrumental deliveries. And again, you must be familiar with the use of forceps, ventus, episiotomy, and types of destructive operations. What is operative vaginal delivery? Operative vaginal delivery refers to an obstetric procedure in which active measures are taken to effect the delivery of the fetus using certain equipments or instruments. That is what an operative vaginal delivery. When you are using certain instruments or equipments to effect the delivery of the fetus per vagina, we are talking about operative vaginal delivery. So, these are the types of operative vaginal delivery that are available. Episiotomy, forceps delivery, vacuum delivery, destructive operations on the fetuses, symphysiotomy, and lastly, the use of Dawson's incisions on the cervix. All of these constitute minor operative vaginal delivery, which can serve as an alternative to cesarean section for delivering live and dead fetuses. Once again, episiotomy, forceps, vacuum, destructive operations on the fetuses, and symphysiotomy. All of these constitute vaginal procedure, active vaginal procedure that can be used to effect delivery of the fetuses in certain situations. We shall start with episiotomy. Episiotomy is a surgically planned incision on the perineum and the posterior wall of the vagina during the second stage of labor to enlarge the introitus and facilitate the passage of fetal head and prevent uncontrolled tear of the perineal tissue. So it's just a surgically planned incision on the perineum and the posterior vaginal wall during the second stage to enlarge the introitus and facilitate the passage of fetal head and prevent uncontrolled tear of the perineal tissue. What are the indications? The indications include 1. When the perineum threatens to tear. When the perineum threatens to tear. When the fetus is presenting in the occipito-posterior position, in breech delivery, or when instruments like forceps and vacuum are to be used to effect the delivery of the fetus. So you require episiotomy in a very narrow subpubic angle, probably in an android pelvis. So you might need episiotomy. When the fetus is in distress in second stage of labor, yes, you may require episiotomy to accelerate the delivery of the fetus. Or a woman who has had a previous vaginal repair, you may want to give episiotomy. And in certain cases where there is shoulder dystocia, yeah, or to control the direction of vaginal laceration, you may need episiotomy. At least you need, these are the few indications, common indications that are available in literature. In modern times, these indications have declined, and many obstetricians do not believe in the routine use of episiotomy. So episiotomy is not used routinely and is not meant for all women. What are the functions of this episiotomy? The episiotomy eases the delivery of the fetal head. It eases the delivery of the fetal head, the easy passage of the fetal head. It protects the head of the small baby from damage, from trauma at the time of delivery. And again, it can prevent uncontrolled tear of the perineum. Episiotomy is less liable to infection and is often performed when the presenting part of the fetus is bulging in the perineum or is about to crown. And in case of instrumental delivery by forceps or the vacuum delivery, episiotomies are always given after the application of the cup or after the applications of the blades of the forceps. Because if you have to give this episiotomy before you apply your forceps or vacuum, there may be a little bit of hemorrhage that could compromise the woman and even the fetus. What are the types of episiotomy? About 4 or 5 types of episiotomy are known. There is what we call median or midline episiotomy. The median episiotomy you give from the center of the fourchette, and extend that incision posteriorly to about 2.5 centimeters from the fourchette. About 2.5 centimeters from the fourchette, center of the fourchette. You give that incision. The advantage of this is that you are cutting through the midline. The repair is very simple, bleeding is less, and the anatomical approximation is very good. But the only disadvantage is that any extension of that tear may go into the anal sphincter or canal. Midline episiotomy, very simple, bloodless, easy approximation. But the only disadvantage is that it can tear to involve the anal sphincter or canal. The lateral episiotomy is the second type. The incision starts about 1 centimeter away from the center of the fourchette and is directed laterally and is cut laterally. In this process, a lot of tissues could be cut. There could be a lot of bleeding, and there could be injury to the Bartolet's gland or duct. And when you are trying to approximate it back, it's virtually impossible to maintain accurate alignment of all the divided structures. It may be difficult to maintain accurate alignment of the divided structures, and the bleeding could be excessive. The third type of episiotomy is the mediolateral episiotomy. This is one that is commonly performed in the labor ward. Mediolateral is the commonest you are likely to see in any of the labor ward. The incision is made downwards and outwards from the midpoint of the fourchette. From the midpoint of the fourchette, the incision is made downwards and outwards in a diagonal straight line, which seems to be about 2.5 centimeters away from the anus and then the ischial tuberosity. It's made diagonally from the center of the fourchette downwards and outwards in a diagonal fashion. And this tends to avoid damage to the anal sphincter because you are moving away from the anal sphincter. It's the commonest episiotomy we are likely to see. The J-shaped episiotomy that is described, it begins also from the center of the fourchette, vaginal fourchette. It's directed posteriorly to about 1.5 centimeters, and then laterally. From 1.5 centimeter, you now go laterally. It's like a J shape. This J-shaped episiotomy is employed in gynecology and is called short incision. It's called short incision, and it's usually employed in the repair of vesicovaginal fistula. Always one. It's not a good episiotomy to use in obstetrics. The disadvantage of this J-shaped episiotomy is that you have to cut through a lot of tissues, and there could be excessive bleeding. So we should know it. 4 types of episiotomy: the median episiotomy, the lateral episiotomy, the mediolateral episiotomy, and the J-shaped episiotomy, otherwise known as short incision, that is beneficial in the repair of vesicovaginal fistula. Repair of episiotomy. This is usually done immediately after the placenta has been delivered. Usually done after delivery of the placenta. What are the techniques of repair of this placenta? 1, you need to take consent for the patient and counsel the patient and let the patient know what is expected. The type of analgesia she will have because of pain. Many of the patients are afraid of pain. So you should be able to take a consent and counsel the patient appropriately for the various steps you are going to take, for the materials that you are going to use. All these things are very important. Yeah, you need to have one of the principles of repair is to maintain a good surgical hemostasis and anatomic repair without excessive suturing. That's one. And the materials that we often use are delayed absorbable synthetic vicryl, delayed absorbable sutures, synthetic vicryl, or a plain chromic cargot, plain chromic. This will be acceptable, 2O for both. If you use a higher strength of sutures, it may lead to infection that may compromise the episiotomy site, and then that may lead to wound breakdown. Yes, how do we now suture the episiotomy that has been given? The first is to assemble the instrument like we have described, get anesthesia, and usually the type of analgesia that we use is lignocaine infiltration of the perineal wall. You give it to the site of the episiotomy. Just about 10 ml of 1% lignocaine or silocaine will be appropriate. But care must be taken that the vessels are not injected so that we do not have a cardiovascular shock arising from the anesthesia, from the analgesia. The perineum is scrubbed and draped, and then you begin the repair from the vaginal mucosa. And starting from the apex of the incision, and then you may use your vicryl 2O and then repair continuously until you get to the hymenal edges of the vagina. Continuously lie down, continuously. Then after the vaginal mucosa has been repaired, then you tend to repair the muscle layers, the perineal muscles. If you still remember your anatomy, the muscle layers are the skin, the superficial perineal muscle, the deep perineal muscles, then before you get the bulbous spongiosis, and then the levator ani muscles, in that order. But you are likely to cut through the superficial and then the deep perineal muscles. And these muscles maybe sutured in interrupted manner. Although some people now suture them continuously, but that may not be able to secure good hemostasis. Interrupted sutures for the muscle layers are better than using a continuous suture. Then after closing these muscle layers in one or two layers, then you now come to the skin. The skin can be closed like as a mattress suture or a subcorticular stitches. I always prepare a subcorticular skin closure. That is my own personal preference. Then after this closure, you need to continue your oral analgesics. The patient are probably awake. Then continue your post-operative antibiotics. This may be controversial because not everybody like to use antibiotics after episiotomy. But in the tropics, where there is a high incidence of infection, or when a woman has been in labor for some time outside the hospital, it may be useful to use antibiotics to prevent further infection. What is important is that after the episiotomy, perineal hygiene must be maintained with the use of Dettol or Savlon to clean the perineum, and then apply a methylated spirit to the skin, and then use a clean pad to cover the wound site before wearing a pant. This will be advantageous. In the past, we used to use what we call seat bath, where a woman has to sit on a bowl containing hot water, where the film of the hot water goes to the skin incision. But this is no longer preferred, it's no longer practiced, because it's shown to increase infection rate of the episiotomy site. What are the complications of episiotomy? Extension of incision, as we have said. Incision may be extended to the anal canal, particularly if you use the median type of episiotomy. There could be infection. There could be vulvar hematoma if there is no good approximation of the edges of the tissues or even the vagina. But there could be wound dehiscence. There could be injury to anal sphincter. Occasionally, there could be necrotizing fasciitis. And one of the long-term complications is dyspareunia, painful intercourse as a result of excessive scar formation. And then there could be perineal laceration in the next labor, or a scar endometriosis or implantation dermosis. All these could arise, both acute complications and late complications. Yes, that ends the subject of episiotomy. And we shall now move to forceps delivery. The obstetric forceps consists of two merged parts that articulate. Or lock. Two merged parts that articulate. And there are many of these forceps. The commonest one that we use is the Wrigley's forceps. We use it in outlet forceps delivery or low forceps, which I'm going to talk about later. The forceps has about 4 parts. We have these parts that is called the blade of the forceps. It's the blade of the forceps. And this area is called the shank. This shank attaches the blade to the handle. The shank attaches the blade to the handle. And where the blade articulates is called the lock. It's called the lock. And this lock can be of two varieties. This forceps that I'm holding is called the Wrigley's forceps. And the lock is an English lock. It locks. Unlike the French forceps, the Quilans. The Quilans has a sliding lock. It has also a blade, a shank, and then the lock with the handle. And the extreme end of this forceps is called the toe. The toe. Let me go back to the blades. The blades has two parts. We said there's a cephalic curve. There's a cephalic curve which conforms to the shape of the fetal head. It conforms to the shape of the fetal head. And then there's a pelvic curve. There's a pelvic curve which conforms to the axis of the maternal pelvis. Conform to the axis of the maternal pelvis. And I've said earlier that the blades are connected to the handle by the shank. This is the shank. This is the handle. Very, very important. Yes. Types of forceps. We are based on their lock and the length of the forceps. The forceps are classified based on their lock and the length. The Wrigley's forceps is short and light-weighted. And the forceps has a generous cephalic curve, a very generous cephalic curve. Unlike this action tracis forceps, you can see the difference between the cephalic curve in the Wrigley's or in the axis traction forceps. In the axis traction forceps, there are about 4 types. And they are called the standard forceps. Like this one is an Anderson's forceps. You can see the traction. And this other one, that is the standard forceps that I brought here, is called Neville-Barnes forceps. If you now compare the cephalic curve, the cephalic curve of the two, you find that of the Wrigley's forceps is wider. This is lighted, this is heavier. But both of them are still English, they still have English lock. The Wrigley's are commonly used as outlet forceps, and they are the most commonly used forceps in today's obstetrics. The standard forceps are still there, but occasionally used because of various complications. And the sliding forceps, the Quilans, are rarely used these days because its plates has probably been taken over by cesarean section. But in very good hands, it's still a very good instrument to be used in rotational forceps. And there's another Piper's forceps that is better in the after coming head of the breech presentation. But again, many people are running away from some of these forceps because of the dangers to the baby and to the mothers. Classification of forceps. There are, according to the American College of Obstetrics and Gynecology, forceps are classified based on the station of the fetal head in relation to the ischial spine, station of the fetal head in the pelvis in relation to the ischial spine, and then the degree of rotation of fetal head. Where the head is not engaged, it is not advisable to use forceps. where the head is unengaged, it's better to avoid the use of it because that means you want to perform a high forceps application. So when the greatest parietal diameter of the head, the greatest biparietal diameter of the head is above the pelvic brim, so this is likely that you want to perform a high forceps and should be completely avoided. High forceps, no. The mid forceps, this is where the standard forceps, the axis traction forceps will be good to use. These Navy bands, the Henderson's forceps, the Maimuri forceps will be better here. Again, as I've said earlier, the use of these standard forceps are, except in very good hands, very skillful hands, they are not always good. In the mid forceps, the largest diameter of the fetal head is between the brim and the ischial spines. The largest diameter of the fetal head is between the brim and the ischial spines. Usually the station is about +2, but the head has engaged. The head of the fetus has engaged, but the head has not reached the pelvic floor. That's mid forceps. And these are the instruments, the standard forceps are used for that purpose. The low cavity forceps, the biparietal diameter is at or below the level of ischial spines. The biparietal diameter is at or below the level of ischial spines. And the head of the fetus is not palpable above the brim. That means the head has engaged completely, and the leading point of fetal skull is station +2. But the head too, both has engaged fully, but not on the pelvic floor. And Wrigley forceps, the light-weighted forceps, is what is available for this low cavity forceps. And lastly, the outlet forceps. The head is visible in the vulva without having to separate the labia. You can see the head fully. The fetal skull has reached the pelvic floor. The sagittal suture is in the AP diameter, and the fetal head is on the perineum. Rotation does not exceed 45 degrees. Because you are seeing the head, it's very easy to apply Wrigley's forceps or any form of forceps to effect delivery of the fetus. Outlet forceps and low cavity forceps are what you are likely to see done in your practice. Low cavity forceps with Wrigley's forceps or outlet forceps. Because in these circumstances, the greatest biparietal diameter of the fetal head has gone beneath the ischial spines, and it is easy to apply these forceps for delivery. What are the indications for forceps? We have known the different types of forceps. We have known the various parts of the forceps. So what are the indications? 1. Poor maternal efforts in second stage. This is not an instrument to use in the first stage because the cervix is not fully dilated. You are using it, poor maternal efforts. The woman is exhausted. It has no further strength to push the baby out. So you use one of the indicators, poor maternal efforts. Then prolonged second stage. In prolonged second stage of labor, the forceps are indicated, particularly in a multiparous woman, a woman who has delivered previously. Where that second stage is more than 1 hour, you say the second stage is prolonged. But in a nulliparous woman who has never had any delivery, your second stage prolonged second stage is 2 hours in nulliparous after full cervical dilatation. So, if there are medical indications that bearing down efforts is to be avoided, or a Valsalva maneuver is to be avoided, like cardiac disease in pregnancy, hypertensive crisis, uncorrected cerebrovascular malformation, or patients with paraplegia, so it's better to use forceps delivery. It's better. Indications. These are maternal indications. Maternal indications include poor maternal efforts, prolonged second stage, maternal distress, and medical indications as I've discussed. The fetal indications, where the fetus is in distress, second stage, you can begin to have fetal heart irregularities, or there's cord prolapse in second stage, encephalic presentation, and control and the after coming head in breech presentation. These are three major indications for the fetus to have forceps delivery. To have forceps delivery. Fetal distress in second stage, cord prolapse second stage, and delivery of the after coming head or breech presentation. Yes, having known the indications, what are the conditions necessary for forceps application? What conditions are necessary for forceps application? Cervix must be fully dilated. The cervix must be fully dilated. The head must be engaged. The head must be engaged. The position of the occiput must be known. Is it posterior, so anterior, or lateral? The membrane surrounding the fetus must be ruptured. The bladder must be empty. And the maternal pelvis must be adequate in size and shape. So there is no room for contracted pelvis. There should be no obstruction below the head, and maternal analgesia must be provided. These prerequisites for forceps application must be known to you, because if you do not follow this, if the cervix is not fully dilated, you are not likely to have a successful forceps. If the head is not engaged, maybe you are dealing with a head that is high above the brain, that means you are performing a high forceps. If the position is not known, if the position is anterior, and you are trying to apply your vacuum, is it rotation forceps you want to do or a traction forceps? So you have to know what you really want to do. A full bladder may cause injury to the bladder, and the woman may end up with vesicovaginal fistula. And if the woman has an inadequate pelvis, that woman may run into trouble. So all these conditions must be known to you. And remember, and check. It's part of your check before you plan for forceps delivery. So I wish to remind that when you are doing that, there must be a cephalic presentation. What are the functions of forceps? What are the functions of forceps? Like forceps, like one, traction. You pull. One of the functions is traction. To achieve traction, pull down the baby down out. Traction. And this you can get with Wrigley's forceps or standard forceps. Then the other second function is rotation. Like a woman who has an occipito-posterior position, or the baby is erected at occipito-transverse position, you can now use your Killian's forceps to cause a rotation to the anterior position and effect delivery. Rotation. Then you can protect the head of the baby. For protection, particularly in the premature deliveries, where between 34 weeks and 36 weeks, premature deliveries, we want to protect the delicate structures of the head with forceps. And lastly, compression. Compression is another thing. Like we have here hydrocephalic baby. Baby is very large, the diameter of the baby is very hard, and you want to compress the baby, particularly when you are doing a destructive operation. So when you compress the baby's head, then you can easily apply traction and get the baby out. So 4 functions of forceps: traction, rotation, protection, and compression. Again, you must know this at all times. TRPC, that's the acronym. Traction, rotation, protection, and compression. Application of forceps. Application of forceps. Before you apply forceps, you must ensure that all the conditions we listed above are established. No presence, the cervix is fully dilated, no contracted pelvis, no bladder fullness, and membranes have been ruptured. All this you must know. Then in applying it, there's a need for analgesia. And the type of analgesia that we use mainly are pudendal nerve block. pudendal nerve block analgesia combined with perineal infiltration. And how do we put in pudendal nerve block? The pudendal nerve passes just medial to the ischial spine. What you need to do is to get about 10 mils or 1% lignocaine, and with your left hand, guiding to the right maternal side, you can guide your needle containing the lignocaine and inject inferior to the ischial spine, and that will take care of the pudendal nerve on the right. And then on the right again, use your right hand and directly guide your right hand, directly guide the needle to the right side of the ischial spine, below it, and inject about 2 or 3 mils of your lignocaine into that area, and the nerve will be blocked. And then infiltrate the pubic area. For further analgesia. So, when all these things are done, you have positioned your patient in dostal lithotomy position. You have draped the woman. The prerequisites for forceps delivery through preliminary examination, assess fetal position, section, adequacy of pelvic, and the membrane, every other thing you do. Do that, or complete all your preliminary examination, and then give your pudendal block and local infiltration. Then you begin to apply your forceps. And how do we do this? When you want to apply your forceps, you assemble them and ensure that the pair of blades match. They match, and make sure they articulate very well. Then the blades, we talk of a left blade and a right blade, depending on the side of the mother the blades will occupy. So, in most of the time, we insert the left blade first. And the left blade is usually held in the left hand of the physician. The left blade is held on the left hand of the physician between the thumb and 2 or 3 fingers. And then the right hand is inserted, on the right gloved hand is inserted into the maternal pelvis, just beside the fetal head. And then the left blade is guided to the side of the fetal head in such a way that the maternal tissues are not encroached upon. So once that one is inserted, your assistant will hold it, and then you pick the right blade. And just between your thumb and you insert the left hand into the side of the maternal pelvis beside the fetal head, and then you gently insert the right blade onto that side, and then you press the right hand. You press the right blade downwards. If you do it in such a way that the right hand, if it's well applied, the right shank of the blade will be on top of the left blade, and they should be able to lock. When you enter, you press them down and it will lock. If it doesn't lock spontaneously, you don't have to force it to lock. You don't have to force them to lock. If you force them to lock, that means you are compressing the head of the baby, and the head of the baby could have a lot of complications, as I will tell you later. So once the application is accurate, the blades should easily lock. And then once they lock, then you apply your gentle traction to bring out the head of the baby. No force at all, no breaking force, and no brute force or the use of black muscles or bracing faith to apply this traction. Just a gentle traction. Once it's locked, and the baby's head can come. And once baby S is coming out, you can now give your episiotomy and then remove the blades in the reverse order. You remember the left one was inserted first and then the right one was inserted last. So first of all, disarticulate the right, raise it up, and then gently remove, and then remove the something last. And once you do that, once after delivery of the fetus, then if you have given episiotomy, you prepare your episiotomy, you prepare your episiotomy and clean up the woman and continue your analgesia because of pain and prophylactic antibiotics if necessary, and then observe in the ward. The forceps delivery, usually by the second or third day, they should be able to go if it's an uncomplicated forceps delivery. What are the complications of forceps? There are maternal complications and fetal complications. Maternal complications and fetal complications. The maternal complications include laceration of the vagina and cervix, or extension of your episiotomy into the anal canal so as to give you a third degree or fourth degree laceration. Pelvic hematoma is a major complication that could occur in many of these people. Bleeding into the levator anal muscles can lead to hematoma and can obviously see the bulging that is soft, very soft, soft in the pelvis. There could be urethral or bladder injuries. There could be urethral or bladder injuries. There could be uterine rupture, and there could be traumatic postpartum hemorrhage that may require blood transfusion. And finally, there could be infection. Fetal complication will include facial laceration because we are applying those forceps to the side of the head. There could be forceps marks and facial laceration. There could be facial and brachial plexus pulses, in which case there may be compression, if those blades are poorly applied. You may have some nerve injuries, brachial plexus injury. And because of the pressure you are having, you may have Kepha hematoma, you may have skull fracture, you may have intracranial hemorrhage. And when there is a Kepha hematoma or cranial hemorrhage, within the first few days of life of that fetus, she may develop some convulsive episodes, seizures. So, and one has to take that into consideration in the management. Many of the times, if the forceps is so difficult, you may have to observe the fetus in the neonatal ward for this complication. Yes, there's a phenomenon called trial of forceps. When you are not sufficiently confident that this instrument will be able to deliver the baby successfully, particularly in a woman with borderline pelvis, then you may say, okay, let me do a trial. You are just, let me try it, whether it will work or whether it will not work. But this is a very dangerous approach in many unskilled doctors. Not a junior doctor should not try a trial of forceps. Not that decision must be taken by a very senior person. And usually we do this trial of forceps with hospital transverse position. When you are doing it with hospital transverse position, you are at the same time preparing for cesarean section because you are not sure whether that procedure will be successful or not. Trial of forceps. And again, we talk of failed forceps. Failed forceps is an unsuccessful attempt to deliver the baby with forceps after 2 or 3 applications. After 2 or 3 applications, do not continue with that application any longer because the failure of you to deliver that fetus with forceps may be due to one, unrotated hospital postural position. It will be due to unrotated hospital postural position, incompletely dilated cervix, and constriction ring dystocia involving the cervix and premature interference. So these 4 may be responsible for the failure of forceps delivery. Having discussed these forceps, we are going to look at the vacuum extractor, which I said earlier that may be an alternative to forceps. So I want to believe that you can recognize the various types of forceps, the types, you can recognize them. These forceps, all these forceps may come out in your orals, may come out in OSCE, and you may have to discuss many of them, their components, their parts, so you must know them. The vacuum extractor was first described in Britain by Armstrongs. What are the components of these ventus? What are the components of these ventus? One, we have the bottle with a manometric meter. The bottle contains water, and the bottle is connected to a pump. It's connected to a pump, a vacuum pump. Yeah. Connected to a vacuum pump. Then there's another rubber tubing that connects to the cups. These cups are in 3 sizes. Initially, when Armstrong started, he was using a metallic cup in 3 sizes: 5 cm size, 4 cm size, and 3 cm size. What I have here is a 3 cm size and 4 cm size, right? But most of the time, we tend to use the 5 and 4 centimeter cup. But actually, the metal cup is more effective than the plastic in achieving a successful delivery, but it's associated with a lot of trauma to the fetal head, and sometimes trauma to the maternal tissues. There are more modern varieties of this Armstrong equipment, Armstrong obstetric vacuum extractor. There are more modern varieties now that are in use, especially the Kiwi equipment. The Kiwi equipment are just coming to the developing countries, and they all operate on the same principles of mechanism. What are the indications of this vacuum extractor? I said they are alternative. They serve as alternative to forceps application, and they are used in rotational forceps as an alternative to rotational forceps, particularly in osteoposterior position and osteotransverse position. And delay in descent of second baby of twins sometimes will be very useful when there is a delay and is head presenting. Fetal indications may include fetal distress, like we said, for forceps, cord prolapse in second stage, and fetal distress. And if the cervix is fetal distress at greater than 7 centimeters of cervical dilatation, maybe a very good indication. Because unlike forceps, you do not have to have a full cervical dilatation. Once cervix is more than 7 centimeters, you can easily use the vacuum cups, because they are not large enough. They are not large enough as to contain the whole. They're very small. They are not as big as forceps. Maternal indications also will include maternal exsuction. Then, if you want to avoid maternal effort in patients with hypertension, cardiac, and respiratory disease. In obstetric indications, we include problem in second twin, delayed distress, prolapse cord, borderline cephalopelvic disproportion, delay in second stage, prolonged labor, elective deliveries, and malrotation or attitudes of deflection. like we have in OP position or hospital transverse position. Contraindications. When will you not use the ventures? When will you not use the ventures? One, in malpresentation. Malpresentation involving the face presentation, brow presentation, bridge presentation, or transverse line. Then where there is a borderline cephalopelvic disproportion, where there is a borderline, more than borderline cephalopelvic disproportion, trial of vacuum is contraindicated. Cervix insufficiently dilated to permit application of a 50 mm cup. If a 50 mm cup cannot be accommodated through the cervix, please avoid the use of vacuum. In an uncooperative patient, it is undesirable to use vacuum. And when there is suspected fetal coagulopathy, the use of vacuum may be contraindicated. Then, if you are not experienced in the use of vacuum, please do not use it. In severe prematurity, where the gestational age is lower than 34 weeks or the expected fetal weight is lower than 2 kilograms, please avoid the use of ventures. Again, if the expected fetal weight is greater than 4 kilograms, because that means the baby is very big and the use of vacuum may not be very successful. So please note these contraindications: malpresentation of various forms, borderline, more than borderline pelvis, cervix insufficient dilated to accommodate 50 mm of the cup in a cooperative patient, suspected fetal coagulopathy, gestational age less than 34 weeks, or expected fetal weight greater than 4 kilograms. All these are contraindications for the use of ventures. The prerequisites for vacuum delivery, just like in forceps, we talk about the various prerequisites for the use of forceps. So we have prerequisites for vacuum delivery. And the first that the baby must be presenting with cephalic presentation and the baby must be well flexed. Cephalic presentation and well flexed baby. There is no evidence of cephalopelvic disproportion. There must not be any evidence of cephalopelvic disproportion. The head must be well engaged. The head must be well engaged. The cervix almost fully dilated, and the obstetrician must be versed to the use of the instrument. Once you have all these prerequisites fulfilled, then your chances of having a successful vacuum delivery is very high. What about the technique of application? Technique of application is the initial process is similar to that of forceps. Patient is counseled, gives consent, permission to go ahead. If you haven't done that, you assemble the component parts of the vacuum. Once you assemble the cups, the bottle, the manometers are suffering, then select the type of cups that you are going to use, and then ensure that the instrument is functioning. Ensure that the instrument is functioning before you use it. So you test run it, and then once you do that, then you want to apply the forceps. The vacuum. Where do you apply the vacuum? Do your vaginal examination again. Ensure that all the prerequisites, that there is no CPD, no cephalopelvic distortion, that the head is well flexed and there is engagement, and then you apply the cup to the flexing point. You apply it about 3 centimeters away, from the posterior frontal, 3 centimeters anterior to the posterior frontal in the sagittal suture. The sagittal suture is that suture that connects the anterior frontal to the posterior frontal. So 3 centimeters away to the posterior frontal is where you apply the cup of the vacuum, and this is what called the flexing point. So as soon as you apply this cup, then you begin to inflate to create your vacuum by pumping, by continuing to create your pressure. over 6 to 15 minutes. You pump, you pump, you pump, and then create, at least in 2 minutes, we are creating about a pressure of 0.2 kilogram per centimeter of water. You create every 2 minutes a pressure of 0.2 kilogram per centimeter of water until you get to a maximum of 0.8 kilogram per centimeter of water. Until you get to that 0.8 centimeters, and then once you get to that level, you have reached the maximum pressure you can use. And then when the woman is contracting, you now apply, because at that time, your pressure that you have created will cause schiedum, production of schiedum or caput succedaneum on the table, on the fetal head. This caput is where you now put your hand on the cup, and then you apply traction horizontally. You apply it horizontally until the head is pushed down and baby delivers. So, and delivery, after exerting more, you don't have to exert more than 4 to 6 pulls before this baby is out. If you are getting beyond 4 to 6 pulls, you may have some problem, and you may have what we call a failed vacuum. When you have a failed vacuum, you cannot go and try forceps. So you just have to go ahead and do a cesarean section. So this what is about about vacuum, about vacuum. That's how to apply it and deliver vacuum. But it's better appreciated in the labor ward when this thing is being done. So I will encourage you to get to the labor ward and observe the procedure in the labor ward live before you can appreciate the importance of application. What are the advantages of a vacuum? It can achieve delivery before full cervical dilatation. It can achieve delivery before full cervical dilatation. And it can effect rotation of the fetal head from hospital posterior position or hospital transverse position to hospital anterior position. It's relatively compared to forceps, it has low trauma rate to mother and fetus. Low trauma rate to mother and fetus. And it occupies less space. It occupies less space compared to forceps. You can see the blade of the forceps. This lot of space compared to the space the cup of the vacuum will occupy. What are the complications from the use of vacuum? Again, maternal complications and infant complications. Maternal complications and infant complications. The infant complications is more. The first that is so common is subgaleal hemorrhage. This is hemorrhage that occurs by bleeding into the subaponeurotic tissue of the scalp. So the bleeding can be wide because the south side just beneath the skin, it can be so wide. So it occurs in about 50 per 1,000 vacuum delivery. Apart from the subgaleal hemorrhage, you can have Kephal hematoma. Kephal hematoma is bleeding beneath the bone, beneath the periosteum. So this one is just in certain segment of the brain, but it has not bled into the brain tissue, but it's confined, unlike subgaleal hemorrhage that is so diffuse. So when you see a baby that has a diffuse swelling on the head, it's more likely to be a subgaleal hemorrhage. But if it's confined to one area, most likely to be a Kephal hematoma. And we can have intracranial hemorrhage, which will cause in about 0.35% of vacuum delivery. And this intracranial hemorrhage can be subdural, subarachnoid, or intraventricular. So this is where major problems, especially if you have to do it several times, and particularly if you do it for premature babies, you can have intracranial hemorrhage. And you can have injury to the eyes. You can have neonatal jaundice post the procedure. can have cerebral irritation and asphyxia, and I can have neonatal convulsion and shoulder dystocia. Then the maternal complications also include vaginal and cervical laceration. Episiotomy may tear, there may be perineal tears, there may be postpartum hemorrhage, there may be infections in the puparia. Unlike the forceps, where you can have uterine rupture, incidence of uterine rupture is very minimal in the vacuum application. Again, we have completed that of a vacuum, and we shall go to our next type, the next type of operative vaginal delivery, and we shall be talking about destructive vaginal operations. The three common things that we do in obstetrics are episiotomy, the forceps, and the vacuum. You see them done routinely. Destructive vaginal operations are not very common nowadays. They are not very common nowadays, because we normally do this destructive vaginal operation for a dead fetus resulting from obstructed labor. And the incidence of obstructed labor is now going down as a result of improved operative practice. So you may not see them much depending on your area of practice. But if you practice in places like Ireland, we would like to see more of this destructive operation done. So, like I said, they are not done in this country for many reasons. They are not acceptable. The experience of destructive operation is not there. There are a lot of associated complications, and there's a declining rate of obstetric labor. This section is now more safe, and many of our women are now more literate than in the early 19th century or the mid 1950s, where you have cases of obstetric labor that kill many of our women. What are the types of destructive operations? Craniotomy is number one, where you have to make an incision into the anterior fontanelle or posterior fontanelle, enlarge that incision, and then bring out the substance of the brain as you collapse the head of the baby. And now, by traction, using some forceps, stout forceps, and now pull out the head of the baby, and the baby comes out. Craniotomy. So you can have an anterior craniotomy or a posterior craniotomy. And it's done. It's the commonest procedure that we do. We do in destructive operation, and it occurs, is seen about 61% of cases of destructive operation. The next destructive operation that we commonly do is decapitation. Decapitation, we cut the head of the fetus, particularly if the baby is dead and is lying transversely in the womb. And there is a hook, which I will show you shortly, that you can decapitate the head and push the head back, and then deliver the body of the fetus, and then later you deliver the head of the baby. So, decapitation. And cleidotomy is division of the clavicles of the fetus. Division of the clavicles of the fetus, particularly in a very plethoric baby, very big baby, like babies of diabetic mothers, in which case they are so plethoric and the shoulders could not allow the passage of the fetus. So in that case, you can even do cleidotomy. Cleidotomy is the only condition that we do in live, the only destructive operation that we do in live baby. Cleidotomy. You cut the clavicles. When you cut the two clavicles, the diameter of the shoulders reduces, and can easily the body of the baby can just come out of the vagina. So once you do that, as soon as you do that, you hand over the live fetus to the orthopedic surgeons to take over the management. Within 3-4 weeks, the cleidotomy will heal back, and nobody will recognize that she had a cleidotomy. And lastly, you can do embryotomy. Embryotomy is removal of the fetus in piecemeals. Embryotomy is removal of fetus impingement, which you do this embryotomy for dead fetus, in which case you want to avoid using cesarean section, because it's going to be a double jeopardy if you are going to do a cesarean section for a dead fetus and you can see the head. So you may want to remove the leg separate, remove the hand separate, remove the muscles of the anterior abdominal wall, and so many things like that. You just remove the fetus out in piecemeal. It occurs in about 0.99%. So these are the examples of this we are talking about. Look at the Simpson's perforator forceps. I'm here with a Simpson's perforator forceps in the first one that you will use after making an incision at the anterior fontanelle. Make a wide incision. You use this Simpson's perforator. Simpson's perforator, you just introduce, because the anterior fontanelle is still open at that time. Then just introduce the sharp aspect, enlarge the Simpson's perforator, and then allow some of the vessels, the brain tissues to come out. And then sometimes, like you can see the diagram below, this is an example of a perforation of the skull. And then you can now use the Simpson's cephalotrope. It can be used, anything that can be used. This Simpson's cephalotrope can be adapted to like any stout. To you use it after making an incision, enlarging the incision with your Simpson's perforator. You can now apply your Simpson's cephalotrope, widen it, and if it's a start to show, you can use it just like doing a DNC to remove some of the brain tissues. And once you remove some of the brain tissues, the head collapses, and the baby can now come out. The blunt hook and crochet. The blunt hook and crochet. If you want to do a decapitation, particularly in a transverse live fetus, you use that hook to bring down the head, the neck of the fetus. You use that hook to retract as a traction mechanism. You bring it out, and then you can now apply this blunt headless thimble and wire, as I've shown it. Once you bring down that, you use the blunt hook and crochet. You use it to bring the neck of the baby down, and then apply the blunt headless thimble and wire. That you can see the wire there. You can now put it one across outside and then move it up and down. In the process, when you move up, there'll be cutting. The wire will be cutting the neck until the neck and the bodies are separated. And once the head of the body is separated, just grab the limbs of the fetus with traction. The baby will come out, and then with your hook still attached to the head of the baby's head can come down. So these are the types of this thing we do. But there are morbidity. A lot of morbidity could be associated with destructive operation. A lot of morbidity could be associated, because usually the major cause of that is obstetric labor. And in our climb here, majority of our patients will probably be laboring in the church for about 24-48 hours before they come to you. So evidence of sepsis. So puerperal sepsis is a major problem. Postpartum hemorrhage is a major problem, because the woman has been in labor for a long time before they come to you. Then there could be a vaginal laceration or cervical laceration, perineal tear, ruptured uterus, bladder laceration, vesicovaginal fistula, rectovaginal fistula, endotoxic shock, puerperal psychosis, and maternal death could all result from this destructive operation. And this is why the prevalence of destructive operation is very low now. And again, as I've said earlier, the prevalence of obstetric labor is going down. And if a labor has to be prolonged in a teaching hospital, there's going to be an early recourse to emergency cesarean section before a stage of obstetric takes place. And this lecture is coming to an end. We will discuss one of the last destructive operation, symphysiotomy. Symphysiotomy is the separation of the cartilage of the pubic symphysis. It's the separation of the cartilage of the pubic symphysis in front. What you need to do is to make a skin incision and then dissect to the level of the pubic symphysis. Identify where the right and the left pubic symphysis are attached together, and then make a scalpel blade and cut it. And then once you cut it, what happens? The pubic bones will separate. And once the pubic bone separates, it enlarges the outlet. It enlarges the outlet or the lower straight of the pelvis. And once it enlarges, the head of the baby can easily come out without any obstruction. That is what symphysiotomy is about. Separation of the pubic symphysis to enlarge the pelvic outlet. Yes, what are the indications? The indications for symphysiotomy: 1, encephalopelvic disproportion with vertex precipitation and a live fetus. Although sometimes the fetus may have died because of obstructed labor. It can also be done in failed trial of vacuum extraction or forceps in second stage of labor. It can be done failed trial of vacuum extraction or forceps delivery in second stage of labor. Again, in breech presentation to prevent entrapment of the after-coming head. It can also be done in shoulder dystocia. Again, CPD, cephalopelvic disproportion, is an indication. Failed trial of vacuum extraction, forceps, breech presentation to prevent entrapment of the after-coming head, and in shoulder dystocia. Here, I have described the techniques in my introduction and what are the complications of symphysiotomy. Because the pubic symphysis where you are making your incision is close to the bladder, so the commonest complication you may encounter is a vesico-vaginal fistula or having a urethral injury with vestibular lesions. So following, occasionally you may have hemorrhage. And one of the long-standing complications in symphysiotomy is osteitis pubic and retropubic abscess because of blood that may accumulate in that retropubic space. And some patients may complain of walking disability because by the time you make an incision on the pubic symphysis, there is what we call a waddling gait, a duck-like gait that may be encountered. A lot of women, more than 50-60% of women may have that walking disability. And they may have pain, constant pain along the pubic symphysis. And again, you may have the woman may have stress incontinence. Note that vaginal delivery rate after previous symphysiotomy is higher than after previous cesarean section for disproportion. That is, vaginal delivery rate after symphysiotomy is higher than after previous cesarean section for disproportion. And the reason is that by the time you do that pubic symphysis, the pubis has been widened. And so if there's an acute, the pubic space is acute before, it probably becomes a little bit wider and can easily accommodate the head of the fetus in subsequent delivery. That's why the vaginal rate is very higher. And lastly, one of the things that we do cervical in the operative vaginal delivery is what we call Dawson's incision. Sometimes the pelvis is adequate. But the cervix is not fully dilated or is edematous as to entrap the head of the baby. And occasionally, this can be seen more in after coming head of the breech delivery, in which case the after coming head is trapped. The baby itself has come out, but the head is entrapped. So when you do this, you can make, with the aid of fine suture, at 5 and 7 o'clock, and 2 and 11 o'clock. 2 and 11 o'clock, you can make your incision, excise the cervix at that 2, 8, or 5 on 7. And this will relieve pressure of the cervix from the head of the baby, and the baby's head can easily be delivered. This is a big problem. Most of the time when you do this, the baby might have died because of the pressure of the cervix on the after coming head of the baby. And again, a lot of bleeding could occur from the incision you are making on the cervix, particularly if you do not identify the area to make your incision. Some people make their incision at 3 and 9 o'clock. That's where the accessory vessels of the cervix enters the cervix. If you make it at 3 and 9 o'clock, the patient will bleed. But it's better 5 and 7, and then 2 and 11. 2 and 11 o'clock. Those are the two sides we make this incision on the cervix. I want to thank you for listening to me, and these are the references. I want to say that this lecture is an interesting one, and its relics in is most of the things that we have said are things that have been done since the 18th century, but with modernization. Many of these are not being practiced, like forceps delivery. The rate of forceps delivery is less than 7% in my own practice. Less than 7% compared to the vacuum. We use more of the ventures in obstetric practice than the forceps. And again, the structural operations are rarely done again, except for certain situations. But episiotomy, not routinely, but commonly done. I thank you for listening to me.